Good afternoon and welcome to Franciscan Health's COVID-19 Virtual Care Journey, a health system CIO Media Inc. production sponsored by NTT Data. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of Health System CIO, and I'll be your moderator today. We're looking forward to some audience participation. You can send in your questions and comments at any time in the Q&A box, and we're also going to do a little poll later and have our panelists guess at the results, which will be a lot of fun. Nice way to view your screen today. First, click at the top center and get it in side-by-side mode. Then you can adjust the divider to get the slides and the video boxes the size you like them. And it should say Speaker View in the top right-hand corner. Just so you see how we're going to spend our time today, first we're going to go about 40 minutes with our main panel discussion featuring Chuck Christian, VP of Technology and CTO at Franciscan Health, Sri Bharadwaj, VP of Digital Innovation with Franciscan Health, and Mary Edwards, President of Provider Healthcare with NTT Data. So we got a lot to talk about today, and we're going to jump right in. It's going to be a great conversation. Chuck, I want to start with you. Can you give us an overview of your organization and your role?
Sure, absolutely. Thanks very much, Anthony, and I'm glad to be here with you today. I'm the Vice President of Technology and CTO for Franciscan Health. The organization is a 13-hospital system that has hospitals in Indiana, Illinois, and about 370 plus physician practices in other locations, imaging centers, lab draw stations, urgent care centers. We have healthcare covered from one end to the other. So I've been with the organization about 18 months and having a great time.
Very good, Sri.
Thank you, Anthony. This is Sri Bharadwaj, Vice President, Digital Innovation and Applications. My responsibility is to manage our application portfolio and responsible for digital innovation, which includes all aspects of what we're going to be talking about today, which is exciting, is virtual care and how we'll be changing the trajectory of healthcare going forward for the next 50 years, probably.
Excellent. Mary?
Hi, Mary Edwards. I am President of NTT Data's Provider Business Unit. And for those of you who aren't as familiar with NTT Data Services, we're part of NTT. NTT is a $100 billion, actually over $100 billion company. And we invest about $4 billion annually in innovation and invention. And the role of NTT Data Services is to bring that, all that investment and capability to our clients and to do that in driving the digital future of industry, in my case, healthcare. And again, in my case, we've taken all of that investment in cloud, RPA, analytics, AI, IoT, right, data and integration fabrics. And we've brought that together in something we call Nucleus for Healthcare, which is essentially helps our clients accelerate their digital front door, accelerate the connection of the end-to-end patient and end-to-end caregiver journey, create the data, and analytics around, care and care provision, and then also support patients and caregivers, as well as those who support them through dynamic workplace, which is a way that we bring the infrastructure, technical and clinical services desks to those who now have to work from anywhere and deliver care from anywhere. So glad to be here, and thank you so much for everyone for participation. We're delighted to sponsor.
Excellent. Thank you so much, Mary. All right, next question. Chuck, I'm going to start with you. Describe the state of virtual care at Franciscan pre-pandemic. So we have, we can measure sort of a before and after. Sure. What were the capabilities and adoption levels?
Well, I mean, we had started on the virtual journey and with one platform, and we had just changed over to the platform that we're using today and starting to flesh that out. And we had a roadmap. It was basically an escalator for to have it go up over time, working with our medical staffs, and in order to incorporate the virtual visits into our standard portfolio of visits, because I'm of the age that I'm getting a lot of well care visits and that kind of stuff, and so giving our patients the option of checking with their physician and not having to drive to the office and spend an entire day, if you will, or actually start looking at how do we provide urgent or emergent care via a visit. I've got granddaughters that their parents are they're working as well, and so giving everybody options of how they want to interact with their caregivers and provide different levels of services for either check-ins or well checks or just having a conversation very quickly with the physician, which could be a phone conversation, could be a text conversation, or it could be a full-blown virtual visit with video. So we were headed in that way, but I think we were fortunate because we had chosen a pretty robust platform to build upon when COVID broke.
Very good, Sri.
So I'll take a different approach. I think if you look at where we are today, decades ago, if somebody fell sick in the house, they would tell the kid or a younger person to say, go fetch the doctor, right? The doctor will come in through the buggy and will prescribe some medication, and and he will probably walk in the door after a few hours, days, depending on where they are, and then provide medication and get the patient well. Guess what? We do the same thing today. Go get the doctor. The doctor is on the phone in a video in 5 minutes, giving you understanding of what's going on with your healthcare, helping you through that care you need through the process, writing a prescription if required, or sending you to your physiotherapist if you need it in a way. But if you look at the practice of medicine and where we are today, it's transcended so much using data that is provided to them in some way, shape, or form. So virtual care is that next generation care being delivered to patients at home, from within their home, by the physician from their home, from within their home, making it seamless, right? Technology use is the best possible scenario you could get in a very, very physical-centric world, is transitioning this. And Franciscan was no different, right? Franciscan did not have all of the physicians aligned to do this work because this is not something that the sisters typically practiced years and years ago. So this is new not just for Franciscan, but for the industry. So we had some capabilities. We had a platform. We had some plans. But what happened was this I would call it an event, kind of transformed the way the organization looked at medicine, not just care, but just medicine as a whole. That's where the difference lies. Today, in the lab draw places, you could do a virtual visit. Never has that happened in the past, right? So let's think about it from a different perspective.
Excellent. All right, next question. Mary, I'm going to start with you. Take me through the February, March, April timeframe as the pandemic set in. What were some of your thoughts? When did you realize this was going to be far different than anything you'd experienced before? Did you have a moment, or was it because it evolved slowly? Depending on your perspective, you could say it evolved quickly or slowly. But
Sure.
Was it a slow thing, or was there a moment that you had when you said to yourself, "Wow, this is big"?
Yeah, well, and not to be trite, but the moment was probably when every conference for healthcare canceled in February, right? Which was going to be live, and then that was quite different to figure out what we do next. But in seriousness, we serve 30 healthcare systems across the U.S. 30 of the largest, and over 500 hospitals, over 4,000 other care sites, and probably more than 500,000 people rely on us for answering questions that help them access life-saving and care tracing, care tracking kinds of technology. So, for us, it was fast and slow. And by that, I mean, we were, prior to any patient volume hitting emergency rooms, we were setting up temporary care sites and all the technology that had to be implemented in those care sites and tents outside of, hospitals on the West Coast. And then on the East Coast, the fast was all of a sudden overnight. I mean, those hospital systems that we support were overwhelmed with, patients, in the care setting, and our people work in those care settings as well. We go into the ER to bring technology. We go into ICUs, to bedsides and, bring technology. And those hospital systems on the East Coast were overwhelmed in such a way that, people from the radiology were now coming into the ER to help, triage, right? And so we have folks who had to be on the phones helping X-ray technicians or doctors and nurses operate in a different care venue. When you talk about virtual care, in some of those settings, there were iPads duct taped to IV poles, being wheeled around rooms, right? So the explosion in virtual care was not just about the patient-doctor visit in the, in the comfort of your own home, but for patient and clinician safety. A lot of that technology was used in hospital settings as well. So, I mean, yeah, they were crazy moments, and the world changed overnight. And then we watched the world, change as it moved east to west, or east and west to middle, if you will, right, as the pandemic spread.
Crazy times for sure. Sri?
From our perspective, I think, I don't know if it hit us or not. I think we just went with the flow. I mean, Chuck, would you agree? I mean, when we looked at it, right, we knew we had to get virtual visits. We were going down a path. Then we said, okay, we're going to go start doing this. And then we really accelerated the process fairly quickly. So for me, I don't know if it was something that I would react to saying, oh my God, the world's falling apart. It was, I think it was for us a business as usual. Okay, we got to do virtual visits. How are we going to help support the physicians doing this? How are we going to train them? What are we going to do? How are we going to move this forward? Well, if I have got to focus on all this stuff and my employees are working from home, am I going to put some things that were more on the priority and the back burner? Obviously, right? So you turn focus. So, this is a I wouldn't call it a moment where we were waiting for, or we were kind of trying to adjust towards. I think we just did it. Chuck?
Yeah. I mean, I'd agree. I think that this was, and it really wasn't a reaction. I've been in healthcare for a long time. Worked in hospitals, and this is no different than you're doing surge management. And trying to figure out what do you do next. I mean, one of the things that we got lucky with is that we made a decision that we're going to move people into their homes to work. Well, in Sri and I's division, there's a little over 500 people. Some could, readily move home. Some have to be there. I've got teams, from networking and site support that are in the hospitals. And so some of those folks had never put on PPE before. And they were worried. And so we had to do reassurance and that kind of stuff. But I think that it was really interesting is everybody, and it wasn't that we collectively had this oh crap moment. It's just that we looked at what the demands were going to be, and we started doing the inventory of two things. One, what equipment, what technology, that's one thing. And then who's the people that I can get to do this? And then, Sri, I'll have to give him some kudos because Sri joined the organization at the beginning of March. And so he basically, the treadmill was turned up to high when he stepped on it. But, he and I have known each other for a long time. And so we didn't have to build a relationship. We had one. So we just attacked it the way that we needed to do. And I've talked to many other organizations and friends of mine at other health systems. They did the same thing. It wasn't, they just instinctively knew what needed to be done in order to care for the patients. And I know you're going to get to this a little bit better, is that we didn't worry about the technology. We were just looking at what do we bring to bear wherever we need to bring to bear, in the hospitals, in our ambulatory spaces. We were standing up freestanding tents and structures outside our hospitals to take care of these patients. We built respiratory care clinics outside of our emergency rooms and outside of some of our larger physician practices to take care and isolate those COVID affected patients. And so we just figured out what we needed to do, what we had to do it with. And was it perfect? No. Did it meet the demand and requirements? Absolutely. And I'm sure we're going to talk about some of the things that we've learned that we're carrying over in practice as I hope we get to the post-COVID era soon. So.
Excellent. Very good. Next question, Mary. How did vendors such as NTT handle the rapid increase in demand from customers? And when did you first get the sense of what that increased demand might look like?
Yeah. I touched on this a little bit, because everybody went to work from home overnight. It sounds like Franciscan, did as well, right? And so all of a sudden, everybody who was used to coming in and, using their tech at work had to figure out how to use that tech from home. And, having supporting that as we do with both technical and clinical service desks, right? Supporting people through those new experiences of not just, how do I work from home? How do I care from a different situation, right? And so it's not just about the increase in demand, because there were a lot of calls coming in, but it's also about, the calls are different. As I said, the folks who worked in lab who are now kind of over in the ER, in the New York area hospitals, I know, that of cases where that happened, they're on the phone asking very different questions and needing very different support. Again, because we operate across the US and frankly, the globe in healthcare, we were able to experience that kind of in the nanosecond that, you light the match and, there's that explosion in a certain part of the US, for that demand, but we were able to quickly industrialize and figure out like what those models needed to look like and how to make them, safe and secure, and then roll that, out as we saw the demand, roll across the US. There are certain parts of the country that just didn't get hit with that demand in the same way, and they had a little more time to breathe and adapt and adopt, right? So I would say we got a sense of what the demand might look like in the wee hours of the first, weeks.
Mary, what do you think, from your point of view and your experience in your career, what do you think were some of the more important leadership traits that you put into action and sort of activated that allowed you to be successful? Because this was, for people in positions of authority, this was a time to leverage everything they had accumulated in their careers and put it into action.
Yeah. That's such a great question. I would maybe say three things. One is, the degree of collaboration across the seams of business, both within our clients and across my firm, NTT Data, was extraordinary. It called for extraordinary, and it was extraordinary in the way that I watched our clients answer that call, and certainly our leadership answer that call. So collaboration as a leadership skill needed, more than ever, right? In that instance, I think service-based leadership, the understanding that you're there as a leader to support the teams who need to make life happen, work happen, care happen, and support, our client base. So, it's not about the hierarchy. It's about, how do we understand what's happening in the care arena, in the field, if you will, and, get around our teams to support them. I think, Chuck, you mentioned about, your team being in PPE. So were ours, right? And we went from, overnight, understanding how to support teams in that situation and do everything from, frankly, hazard pay, just to support them and the changes that they had to make in their situations to be in the care arena, sometimes, sheltering away from their families because they had high risk, family members at home, to crisis counseling, because some of those care settings were really intense. And, what everyone was going through in some of those moments, required a different level of employee support. So service leadership, collaboration, and then, cut through any kind of process or bureaucracy or decision, making that isn't serving you well, right? Just figure out how to get from, A to Z with no steps in between was something we had to implement quickly.
Excellent points. Appreciate that, Mary. Thank you. Sri, let's start with you on the next question. What were some of the steps that you took to empower the health system to deliver virtual care? Obviously, we'll go to Chuck next, but Sri, go ahead.
So for us, I think getting together with leadership was the first thing we did. We identified several leaders in the organization who would be our physician champions, our operational champions, right? So once we understood who those champions were, we started figuring out how to help them understand how we can deliver this care. That kind of solved some of the operational questions that we were going to get, because we allowed them to speak to the operational impact, as well as the ability for them to do the scheduling, the actual visit, the documentation of the visit, billing for these visits. All of that stuff took a very, very operational role. From a technology perspective, we, of course, mobilized our teams. Both Chuck's team as well as my team pulled it together, and we started working through several scenarios that we would have to establish. And we also came up with several innovative ideas on how do we deploy a virtual care type environment in order to make it work for us. So, give you a simple example, palliative care, right? Patients who would like to talk to their, their kith and kin during that time of phase in their lives, right? Patients who were in the hospital but unable to talk to anybody, unable to be visited by other people, giving them the ability to have that conversation together with the nurse in a way to understand the care team process and response to that patient. Hospital outpatient departments. How do you take an ED doc to do an ED visit without actually stepping out of his office inside the ED, right? Very, very unique, something we would not have ever done before. But those were the things that we took to come up with options. And you know what? The best thing is we found is that the person closest to the problem delivers the best solutions.
Mm-hmm.
It's unbelievable. So you allow your employees to identify options that they think will help them. They will identify opportunities that we need to be able to support them. That is what we do even today. We got physicians who said, look, this thing doesn't work for me. We got to go do this. Fine. Let's figure this out. In the olden days, I shouldn't say olden days, but there are a lot of old people on this call, including myself.
Thanks.
So in the previous days prior to COVID with Franciscan, the process would have taken at least a few months for them to find the leader, identify, make it a priority, help them understand it, and so on and so forth. Here, we did it in a day, in sometimes 2 days, without even blinking an eye. So when we got an idea, we empowered our people, got an idea, identified an opportunity, found out that there is a physician champion who's going to go do this. From a nursing perspective, find out a nurse who can do this as well. Got it, pulled it together, delivered it. That is how quickly we were doing this as we moved along. And beginning to think, have the ability now to actually take a step back and think about it. I don't know how we did it, but we did it because that is how we operate. We operate extensively well with that kind of a mindset that at the end of the day, patient care is the primary reason why we exist.
Yep.
Chuck?
Well, I mean, I agree with everything that Sri said because we kind of, we did this together. And it wasn't just me and him; it was the entire organization. But one of the things that I watched the organization do is that we listened very carefully. I remember one Sunday evening conversation that we were having with a group of physicians and other leaders in the organization about what they wanted to do, an approach they wanted to take. And so rather than us doing what we typically do of figuring out why we shouldn't do this, because we had security on the phone, we had our firewall guys on the phone because we were wanting to do things that we typically don't do, but the physicians were saying, if we can do this, we can take care of our patients better. And so the mode changed to how do we make this happen without worrying about all the red tape and the framework and all that stuff. And so the next day, just like Sri said, we had it up. The people worked through the evening in order to get it done and to make it happen. The other thing we did is we partnered with our physicians, and we're still doing that today, of coming up with very creative, innovative ways of using the technology that we had recently put in place so we could do virtual things. And not just the virtual physician visit, but as Sri mentioned some of these, is we were doing virtual palliative care where we were letting the patients visit with their families who couldn't be there. We were doing virtual discharges where the patient's family or caregiver was at home, and they were participating in the discharge process while the patient was still in the hospital. The family member was at home, but it was full video. The other thing that I thought was extremely creative, and I know this is carrying forward, is what I call collaborative rounding. Is you had one physician or a nurse and a team going into the patient's rooms, whether they're COVID positive or not. They had an iPad, and then in a conference room somewhere else in the facility, you have all the rest of the care team. You have the other physicians, you have a pharmacist, you have somebody from PT, you have, from somebody from respiratory therapy, and they're reviewing that patient, and they're changing the patient's care plan in real time. And it had a profound impact upon, rather than people trying to chase folks down in order to do a quick consultation and that kind of stuff. And I actually watched the physician that says, I need to talk to this physician. Well, he just pulled out his phone, dialed him up on a Teams chat, asked a couple of questions, and then they modified the care plan. And so this, to me, this is care in real time versus, trying to chase people down. Then we also did some, what I call communal discharge planning, where you had the same group of caregivers, because most of the people that had COVID that were sick enough to be in the hospital, they have a lot of comorbidities. And so you're going to have a lot of different specialties are taking care of them, pulmonologists and cardiologists and, and typically a hospitalist. And so if you've ever been a nurse, or a nurse, and go ask them how difficult it is to discharge a patient like that, because you have to get consensus about the patient can be discharged and what's the medications, what's the plans. And so this allowed them to do this stuff in real time. And so this is where I think that the technology can have a profound impact. And the fact is, it wasn't that we're leveraging the crisis, is the crisis changed our mindset So we think about these problems and these things differently, and how can I engage from a technology standpoint with the people that are providing care to let them know that I'm going to partner with you to make your life a little bit easier, but we're all focused on the patient. So I think that, as Shri said, at the end of the day, it wasn't about how cool the technology was, it's how do we take care of those patients that have entrusted their care to us, and the fact that, you know, we work for the sisters. And so the Sisters' mission is to, you know, provide excellent and outstanding patient care. So we get to help them do that every day.
The one point I'd like to add as well, Anthony, is that even though we did these things rapidly, quickly, and we always took care of security, which was paramount, right?
Yep.
That needs to happen. I mean, you know my background with security, right? So. So anything we brought together, we had the security folks aligned with what we needed to do. We made sure there were appropriate controls in place to make sure that truly happened. And at the same time, when we spoke to compliance legal, I remember this conversation at 5 o'clock in the evening with compliance and legal, difficult to get them on the phone, multiple attorneys. That when we did that, there was several sets of questions we went through, right? And we knew what we needed to do, but it was also in a way that we are protecting patient data, encrypting with the right technologies, helping put the right controls, making sure the right consent was obtained from the patient. Right? These are important things when it comes to delivering virtual care. So even though Chuck says, yeah, we went and did it in a day or two, yes, we did it in a day or two, but we did not miss a beat in any of those aspects as well, which is the toughest part in our lives when doing it otherwise, because to get all these approvals and everything else, it does take time in any organization. But if you have the framework, we have what we call a security compliance privacy committee. So use that committee, use members of the committee to actually deliver that value to you. That is more important.
Well, the other interesting thing, Anthony, is no one had to ask anybody to, you know, let's extend our work day. Let's extend our work week. And, you know, there was never a conversation about that, which I found, you know, refreshing, is just that everybody knew what needed to be done, and it didn't really make any difference what the time frame was. You know, 6 o'clock on Sunday evening, if that's when we can get everybody together, that's when we did. And, you know, using the collaboration platforms we did to pull these people together, which was really interesting. So I think that it was, Mary, I think you mentioned a collaboration and the willingness to partner and put teams together in different ways that we typically wouldn't have thought of, in making sure, you know, Shri and I have been doing this for a long time, and so we know what the moving parts need to be. We know where the approvals need to come from, and we know that, you know, we think we have an idea of who we need to engage in order to get some of this stuff done. And it's just a matter of execution at the end of the day.
Very good. What I want to touch on a little bit, you know, we had a lot of great stuff come up so far. I want to talk about the aspect of leadership that I think, Chuck, you exemplify, and I want to hear from Mary and Shri as well, which is that, you know, Mary talked about clearing obstacles, so to speak, right? When you decide what you want to do, and then it's a leader's job to clear obstacles and clear the way. Chuck, I know that, you know, you've made comments that I just love about an intolerance for status quo, an intolerance for pushback that you think is unwarranted, you know, an intolerance for not moving forward with what needs to be done. So I want to talk a little bit more about that. Mary, I want to get your opinion and the way you approach that. When you run across obstacles, either from people, partners, maybe even customers, employees, you're running across pushback. I think great leaders handle that the right way. They don't let it stop them. They push through, but they also do it in the proper way. What are your thoughts?
Yeah, but just thinking about the situation and how little, you know, pushback there was, I think Chuck and Shri, you know, talked about that as well. But, you know, just thinking about that in general, I mean, I said servant-based leadership, and, I kind of really mean that. I think of my job as enabling, the teams. And once in a while, there is a team member who's not willing to do something. And my approach is to say, fine, I'll do that, right?
Mm.
You lead by example, and you usually don't get the person saying they won't do it again. If I'm willing to take my time to do it, then I guess, they can do it too. Once in a while, you find leaders like that, not just team members, but leaders, right? Who aren't as effective at collaborating. And it's, how do you use kind of a servant-based leadership mentality to deal with that, and, lead by example, lead by doing. And, the point is to get it done. And so to demonstrate that it doesn't matter who we are, where we are in the hierarchy, we're all here, to serve. And sometimes someone legitimately doesn't know the way, can't do it. And so helping them get through that is important as well. That's probably my
So we would hope, well, that's good. That's an interesting point. So we would hope that you saying, well, fine, I'll just take care of it, we would hope that would get a message across.
It usually does. It's the way you think.
There's an oh moment that comes after that. Oh, really? Yeah.
Go
ahead, Chuck. Chuck, I want to hear from you. I love your approach to these things. Just the Chuck look. If you were got a response, if you got a response you didn't find was appropriate, I picture a 2 to 3 second stare before you did anything else. That would pretty much get the whole message across. But tell me your thoughts there.
Well, I mean, y'all know I was raised in the South, and so my response is, well, bless your heart. And so that is Southern for you're dumb as a box of rocks, and do you really want to say that? And so the thing about it is that, the thing is, you kind of painted me as being intolerant. I don't think I'm intolerant. I'm unacceptable of certain behaviors. And I think Sri has seen this in me over the course of years, is that, I have a job to do. My job is managing individuals. That means getting work done through them, not me doing the work all the time. But I think that we have to look for those teachable moments, because another part of my job is to build the people that are below, not really below me, but that work with me in order to accomplish the things we need to do. And I tell everybody, if I walk into a room and I'm the smartest guy in the room, I need to find another room. Because I am not the smartest guy. I'm going to have a lot of questions because it's just built into my personality index. And I'm going to explore it a little bit. But, I'd like to understand when they say things like that, I want to know the why behind that. Is because they just don't think it's important, or they think it's beneath them to do something like that. And, my teams know that I'll never ask them to do anything that I won't or can't do myself. And I'm not a perfectionist, unless you ask my wife. She'll tell you that I'm pretty picky. But the thing about it is that, part of it is to engage our workforce and give them opportunities to grow. And if they choose not to, then I have to help them be successful in other places, not this organization. So tough thing to do, but it's just reality.
Sri, I'd love to hear your take. I don't imagine, you're one that puts up with obstacles when you don't think they're fair or appropriate. So what's your approach to dealing with that type of thing?
So first, you got to build what I call a high-performing team, right? You have to surround yourself with people who you believe will perform when you need them to perform.
Mm-hmm.
That's an important factor. As a leader, that's your job, right? And in some respects, I sincerely believe that every employee comes into work to do his best, not for that day, but for his career and for the organization he or she is working for, right? That is a sincere belief. Now, that is the same belief I have in myself. So I bring that to work every day. So when you are with that kind of a spirit going into work, making sure you have to deliver the best for the organization that day and for the future, you will surround yourself with that kind of people. Number one. Number two, yes, there are people who will say, look, that's not my job, or I can't do this, or whatever. That's fine. And my point is, thank you. I really appreciate the fact that you can't do it. Let me find somebody who will do it for me, right? So that tells them that it's a choice that they made, right? It's a choice that they make. There are people who make choices, which you say, look, it's something that they cannot do. And that means they choose to self-select themselves out of the process, which is perfectly fine. Not everybody wants to do the same thing. We just have to find the people who will help us deliver. And as Chuck said, right, roll up your sleeves, get it done. If that's what we needed to do, and that's what we are here for, I'm not ashamed to say, look, I don't know, I'm willing to learn. But at the same time, I will say I'm willing to learn, but I'll put the effort to do it. I'd expect all of my employees also, staff also, to be looking at doing the same thing. So it's about collaboration, communication, the level of leadership you need to create and maintain a high-performing team. And, you know, every member of my team should be able to say, okay, I know this needs to get done. And I can tell you, this is very, very telling. Many of us do not even consider a 9 to 5, 8 to 5 as a work situation anymore. Most of us, when we get up, we're on a system in some way, shape, or form, you know, looking at things. And the day doesn't end at 5 o'clock and we are driving, right? And right now, we're working from home, you're working long, long hours. Now, I mean, some days I've not had lunch, worked through lunch many, many days, right? You don't have that, you know, moment to get up and go to the water cooler and have a conversation, right? You are on the system all the time, almost, in a way. And it is important that we accept that that's our life, but that also has to be in a level of caution, right? So I tell my staff, you know, guys, you might have to take some time off just to, you know, get your rhythm back, because sometimes it just keep going. You just never know. And I've had several directors who tell me, see, I've not stopped to have lunch. This is about 3 o'clock in the afternoon, right? And then I found out there are several employees who don't get up from their chair once they sit in, which is bad for their health, right? We are in healthcare, right? So you think about all of this stuff. These are the challenges that we deal with, not just the fact that somebody says, I can't do this or I don't want to do this. That's what I think we need to take a look at. Take a step back, look at the forest, understand what's happening in that environment. A lot of EQ is what is required to develop the skills in this marketplace with this kind of a scenario. Not everybody, not every leader is able to transform themselves to look at that from that perspective.
Great points. Excellent points. All right, I'm going to throw out our audience poll, and I want everyone, including our panelists, to answer it. If not intentionally sustained and nurtured, innovations developed during the COVID-19 crisis will disappear as employees go back to old, familiar ways of doing things. Is that something that we have to be concerned about, that we have done some very cool things, but things are backsliding? And we see a little bit of it with telehealth numbers going down. So let me throw out an audience question that is really about that. Virtual health has been widely accepted by patients and physicians. However, future reimbursement by payers for these services is uncertain. How does this dynamic impact your plan to invest and deliver future telehealth needs? Chuck, let's start with you.
Well, I mean, I think that, you know, there's already signaling from DC that, you know, from a Medicare standpoint, Medicaid, that they're going to continue to reimburse virtual visits the same way they do as in-person visits. However, I think that any sane person would understand that, you know, there is an opportunity for fraud and abuse. There is opportunity today for fraud and abuse. I can't tell you that, you know, it's almost every week I read about someone is being prosecuted because they fictitiously sending claims related to visits that they didn't actually complete, and so we just need to have to watch it and do it. But I'm hoping that this is a service that's going to be continued to provide it. I'll give you an example. Dr. Randy Moore, who's one of our senior vice presidents, his father, who is in his 90s, is a cardiac patient. did virtual visits with his cardiologist. Now, he said his 90-year-old father said, you know, I kind of like this. I don't have to leave the house. I'm just doing a check-in with my cardiologist. He wants to know if I'm okay, how's my weight, and you know, am I retaining fluid and that kind of stuff. And I give him all the information. He says, save me a couple hours round trip going to the cardiologist. He said, I kind of like this. And so I think that, you know, that's the other aspect of this. What's good for, you know, the physicians and the medical staff, but what's also good for the patient. You know, I think that, you know, some of the people said that people my age that are not as accepting of the technologies and that kind of stuff, but I'm not sure that's actually true. And I know that the younger people, you know, I know my kids who are in their late 30s now, they're doing virtual visits on their phones. Wherever they are. And so it's a matter of, and I'm not talking about making medicine convenient, but I'm talking about engaging the caregiver appropriately, because my wife's a critical care nurse. I guarantee you, at least once a day, one of my children is engaging their mother with a, I mean, I can't tell how many times that one of my children has sent her a picture and says, well, what do you think this is? You know, and she's saying, well, I don't know. And so we're looking it up. Well, it's a spider bite. So, you know, engage your physician rather than your mother. And so, but they can get to their mother on text faster than they can get to their physician. So it becomes a matter of convenience.
All right. For the sake of time, I want to get to the poll results, and I want to have our panelists guess at the percentage agree. So what percentage agree with the statement that we will backslide on innovation? Mary, I'll put you on the spot first.
40%.
40%. Shri?
I don't think we'll backslash a lot, so probably 20%, 30%.
20%. Chuck?
I'm going to say about 50-55%.
Between 50 and, well, can you pick a number, please?
55.
55. All
yeah.
right.
If you have, so I'll be intolerant.
Hey,
right.
I'm the innovation guy in the room. I have to be the most optimistic, right?
This is true.
Actually, the winner is Chuck Christian. 52% agree with the statement that it's really got to be sustained and nurtured, or you're going to backslide. So now I want to go to our Ask a Co-panelist. Mary, I want to give you an opportunity to ask Shri and or Chuck a question.
Oh, thank you. Yeah. So I guess the question I would have is, in what way has what you've experienced shaping your next steps moving forward? You had a plan for virtual health, I'm sure, before any of this happened. And as most systems did, and you know, they were seeing low single digits adoption, right? Now this has happened. How has it changed the shape of what you do next?
Shri, you want to jump in first?
Sure, yeah. I will. We actually have made digital virtual health a primary strategic investment opportunity. This has been not just, you know, it's not just coming from IT, but it's a organization-wide effort, number one. Mm-hmm. Number two, we are looking at new ways to do this. What Chuck talked about, you know, the physicians in a conference room consulting with the patients. We actually saved, you know, probably 2 to 3 days in length of stay by bringing the care team together. And that is exactly where the healthcare industry should be looking for, right? Saving length of stay days and avoiding readmittance is this nation's big saving grace that will come through this process if they all follow through, right? And we are looking at that option. The third option is, of course, we got, you know, tele-nocturnist program, tele-neuro program, you name it, we've got a tele in front of it, right? That has changed the way we think, right? When we've got vendors knocking at our doors, giving us solutions, that has accelerated them to do things differently, which did not happen before. And that is what I believe is the future for healthcare.
I agree.
Well, yeah, so and for me, I think that it's taught us that none of the stuff that we did has a technology lead on it. It has a purpose lead, and how we partner with our physicians and how we work with them to innovate. And not only just the physicians, but we're doing in our ambulatory departments with physical medicine, with occupational therapies, with a whole bunch of different things of taking a different approach of how we engage digitally with our patient population. And, some are not as comfortable as others, but I think that we have to at least engage that, because over time, it'll become more comfortable. I mean, it's no different than like us. I really wasn't, and I know my wife wasn't comfortable with me working at home every day, but now, well, I'm still not sure she's that comfortable, but I'm more comfortable working at home. And Sri and I were in the office on Tuesday this week. And we're trying to get back in 1 or 2 days a week to get back in the routine, because we can see each other on the screen, but it's not the same as being in the same room. But we were appropriately socially distanced. We have a very large conference room. There were about 10 of us, and we were spread all over the place. And it was appropriate. And when we weren't, we had we were had our mask on as we were ambulating around the building. So I think it's how we work with our caregiver teams and our other departments that we typically don't partner with. I mean, we talked about that at our leadership meeting this morning, is how do we engage a little bit differently from an IT leadership with the other business owners and our business relationship managers, because we kind of have a creed, if you will. It really is that we are operationally led, clinically focused, and technology enabled. And some of the stuff that we're doing really feels like we're, technology led, because, the technology is leading. We need to change that a little bit more and keep moving forward with that.
Mary, I want to give you a chance for a last thought. With what we've been through in this year, and it's not over yet, so who knows what else is coming, but it makes me think, and I've heard other CIOs, CTOs, and folks like that talk about the importance of being able to handle anything from a technology point of view, to have that foundational level in that you can handle whatever comes at the health system. So if you want to address that, or anything you want to address in some final thoughts.
Sure. I think I'll, pick up on what Sri was saying about the many vendors, right, with tell us something, coming at you. And how do you stitch all that together, and how do you, which is where we've been focused, right, at NTT, is you're going to have all these enabling technologies, and then you've got to make sense of it for the patient journey, and make sense of it for the caregiver journey. So how do you create the integration fabric, the analytics fabric, the things that ride, the cushion that rides on, right? So that, and so many things will be popping in and out, right? New capabilities emerging now that we're, kind of tipped in this direction. And how do you create the ability to seamlessly bring those things in and out without disrupting the caregiver and patient experience? Those are the things we've been thinking about. And I know CEOs, across the healthcare system, even before the pandemic, were focused on digital front door. And I've just seen, as Sri and Chuck were saying, an increased pressure and velocity, and actually investment posture around that, because the industry is restructuring, around, the virtual state, not just virtual health, but the virtual state of operations, and, many different things that we have to execute as a team. So thanks for that. Thanks,
So Anthony, there was one question that got asked that I want to touch on just real quick about how do you address the the leadership stuff with your peers, which is the other leaders and that don't directly report to you. To me, that's it's I haven't experienced that at Franciscan. We just work together to get everything accomplished. But I know that there are situations where people are their turf, don't get in my space and that kind of stuff. Shri and I both have security backgrounds. We partner with our CISO. We don't get in his way, but if we see something, we say something. We offer consultation when asked for it, and me, I'm a shy guy. I'll have a tendency sometimes to speak up. But the thing about it is, I think that we have to do it in such a manner that it is constructive, and we understand some of the motivations. I think we as a leadership team have just gone through a leadership institute that Charles put us through, and he participated in as well, about looking at your personality index, which I mentioned earlier. And I think that that has helped me understand a lot about how Charles manages, who's my boss. And Charles, I have to say that when Charles looked at my PI, and he's sitting across the table from me, and he says, "Now I know." And I'm going, "Crap, what do you know?" So I asked him, he says, "No." He said, "Looking at your index," he said, "I know why you're so good with people." And in his index, he's not that warm and fuzzy kind of guy. He's way over to the right on the A, so he's basically tapping his foot saying, "What's next?" And I'm over here trying to figure out the relationships and that kind of stuff on the other side. So we are a good offset. Shri is a very high A as well, as you can tell. He likes to get things done and move on to the next thing. And so I think how we learn from each other, of what drives us in certain behaviors, is extremely important. And so I would suggest, if folks who are listening are struggling with that, work on, see if you can't put something like this together so you can understand how each other are wired. And because when you get in crisis, that's what you're going to go to, what feels comfortable and what you know. And just like what we went through, that's kind of my recommendation. So.
I got to give Shri 30 seconds to defend himself.
From my perspective, I think you are here to get done. You are here to get done for our patients. Patients are primary. Patients are important, and that's the reason why we exist, right? We are here to save lives. And one of the key things that we did as part of our virtual analysis is that patient experience. What is the patient actually accepting with what we are providing to him or her? It's a very important question that we ask every time. And we actually have a video that's posted on YouTube, I think now, where a patient actually talks about virtual visits. The one that we talked about, it's actually a nice video. It was a very, very old patient who really did not understand what virtual visit means, and he still talks about it. It is good to see our patients also taking into consideration. And in some respects, some of our patients are pushing us down a path. I'll tell you another example. A patient drove over 60 miles from home because he didn't have internet, but didn't want to step into the clinic. He walked out, he came to the car park, parked his car, got the iPad, had a virtual visit, went back home. Phenomenal story. Drive-in care, right? That's new. That's not something you would ever have done. I mean, our cardiologist saw the patient. He saw the patient virtually outside his office in his clinic. But this is what I would call physical visit into the clinic, right? Because that really helps some patients. That is the kind of thing that we need to take a look at. That is the kind of thing that we want to do. And that's what I'm propelled to do. I love the talking to Chuck and give me some feedback. Hey, Chuck, this is what I'm thinking. He goes, so you might want to think. Right? I go, yeah.
I'm shy. What can I say?
Of course, right? So and then he's like, Shri, Shri, this needs to happen. I'm like, okay, got it done. Right? There is that chemistry you need to have with people. But understand motivation, understand backgrounds, understand their philosophy and their thinking. You get a better leadership out of that process.
All right. Well, I just want to say that any organization that puts Chuck and Shri together is an organization that I want to go to when I get sick. So
come on down.
I will say that for sure.
Yeah.
All right. Regarding continuing education, you could use the final slide in this deck. You'll get an email when the on-demand recording of this fantastic event is up. If you want to sponsor an event with us, you can reach out to Nancy Wilcox from our team, and you can go to our website to register for our robust lineup of upcoming events. With that, I want to very much thank our panel, Chuck Christian, Sri Bharadwaj, and Mary Edwards. I want to thank NTT Data for making this event possible, and I want to thank you, our attendees. With that, everybody have a wonderful day. Thank you.
Thank you.
Thank
Bye-bye.
you.